Okay, so are we officially starting? Let's do it. Welcome everyone.
Hi.
To the Hormone Party in honor of World Menopause Awareness Month. Happy October. I'm Jaymie Adachi. I'm a nurse practitioner at Cape Gynecology in Brewster, and I'm happy you guys are here. Let's have some fun with hormones. We're going to be talking about women and women's health, how we see ourselves as women and as patients, and how healthcare providers see us as women and as patients. Healthcare providers are trained in the art of pattern recognition. This is really important when you come into a doctor's appointment, you have any kind of concern at all. Their job is to figure out what your concerns are and connect the dots to see, is this one problem, is this more than one problem? And this is so important so that they can make an accurate diagnosis and a helpful plan of care. So this is pattern recognition is about connecting the dots. I want to start to draw some attention to the fact that we connect the dots we are taught to look for. And these are based on our medical training, but medical training is also based in larger cultural ideas. And what's taught is what's considered important. And so what's not taught is not considered as important. And this has some pretty major implications in women's health. So, party favor, number one, for coming to the hormone party, hormone goggles. And the idea is to start to be able to see some things that you couldn't see, you couldn't recognize before. Today, we're going to talk a lot about visibility and invisibility. And here's your tool for seeing that. I have asked a childhood idol to come help me illustrate this point. This is, of course, you know who this is, right? Wonder Woman, right. Does anyone remember, what does Wonder Woman drive?
An invisible car.
Thank you. Invisible plane.
Plane.
Yeah, right. So there's the invisible plane.
I don't know why.
Yeah. Invisible plane. Super powerful, does all kinds of cool things, can't see it, okay? Hormones, super powerful, super cool, all kinds of things they do, can't see them, okay? So we see our analogy here, visibility and invisibility. So we all know gynecologists are the bosses of women's health, right? A gynecology degree takes a really long time. Anyone want to guess how much time in the 8 years that a gynecology degree takes is devoted to menopause, perimenopause care?
Probably about 6 months.
Oh. Any other guesses?
1 week. A year. Oh, it can't be more. 8 weeks.
So it's about 2 hours. And that's often optional. Yes, yeah. So it's getting a little bit of a glimpse of what's considered important is what's taught, okay? And so there is always an unspoken implication. If it's not taught, it's not important. So we come to think about, how do healthcare providers see you? I'm going to share stories of 2 other doctors. These are public stories. These are doctors and writers who have shared this publicly. The first is a gynecologist, Dr. Haver, who practices in Texas. I don't know if any of you have heard of her. She talks about when she was training for OB-GYN, that when they came in to do their rounds every day, they had their good patients that they saw, and then they had their WWs. This is what they were called. This is what was said every day. This is what was taken in. WW stands for whiny women. What did all the WWs have in common? They were all past reproductive age. This was the language that was used commonly, okay? Another story from a doctor, Dr. Casperson is a urologist. She practices in Washington State in urology training. Their cohort, and presumably all the others, they were told to make sure they chose a fellowship where they would not have to see women. And this was reiterated all the time by female faculty too, by the way. They were told women are too time-consuming, too complicated. We will never figure them out, so don't try. Dr. Casperson, fortunately, didn't take this advice. She went into general practice. And she shares this story about one of the first patients that she saw was a postmenopausal woman who was having really severe pain with sex. And Dr. Casperson, the urologist whose training is in pelvic function and dysfunction, realized her training was in male pelvic function and pelvic dysfunction. And she figured the gynecologists are covering this stuff, right? And she realized she didn't know how to help the patient, but she took it upon herself to find out. And she said to the patient, I really do want to work with you on this. Can you give me a little time? I'm going to get myself up to speed, come back to see me. So
I wants to go to the
women's sexual health conference and was surprised when she got there to find out all the other attendees were what? Does anyone want to guess? They were not. And they were mostly not urologists either. They were
Psychologists?
They were gynecologists.
Oh.
They are not getting this training either. Yeah. So interesting distinction here. Urology is devoted to the study of sexual health. Gynecology is devoted to reproductive health. Okay, so we could start. Yeah. Right. So this message that they got, women are too complicated. Is this true? Maybe. If it's true, probably because of hormones. The hormones the ovaries produce have a profound effect on the brain. This is, I'm going to struggle to say this, hypothalamic pituitary ovarian axis. We're going to call it the HPO axis. And women are hormonal as a result. And this is really important and valuable to understand about women's health and women's function. So we see it that way culturally, right, of how important these hormones are. Well, to say a woman is hormonal, we all know this is a negative thing, universally understood to be negative with quite strong connotations, right? Dumb, like a bimbo, immoral, like a slut, unreliable, like an impairment, dangerous, like a witch. All kinds of historical implications here. Is this really embedded in culture and language? I could go on all day about this, but I'm gonna, make it brief. There are negative connotations for almost everything to do with women's biology that does not pertain to men, right? We don't talk about periods in public. We're saying we never talk about menopause in public. People hide in toilets to breastfeed their babies, right? Menstrual products, we call them feminine hygiene products, implying we are unhygienic. And does anyone know the Greek root for the word for uterus? So what's it called if you get your uterus surgically removed? Hysterectomy. Hysteria and hysteria. Yeah. Right. So premenopausal women have menstrual cycles that are controlled by hormones, but women's whole bodies cycle as a result. It's not just about menstruation. And that does make us a little volatile, and to put in Cape Cod terms, a little stormy. In language we can understand here. As long as there's a monthly, what I call the uterus party, right, and there's still possibility of getting pregnant, hormones are considered to have a positive connotation, and that's fertility. And that's kind of it, okay? When women are no longer throwing a monthly uterus party, the hormones or the loss of hormones don't seem to be as important. Because we don't talk about it. There's this culture of invisibility. We're not taught about it in training. So invisibility upon invisibility, and that hurts women. Because, as I say, hormones supply the drinks for the uterus party. We think of them as sex hormones, but that's doing them a disservice. These are the ovaries produced by, sorry, I said it wrong. The hormones produced by the ovaries. These are estrogen, progesterone, and testosterone. But they are not just sex hormones. They work on the entire body until they don't, right? When the ovaries go offline in menopause, that's when we stop having estrogen, progesterone, and for the most part, testosterone. And that's when the uterus party turns into the after party. And the after party is dry.
No drinks.
When women's bodies shift from the uterus party to the after party, the hormones, the loss of hormones, affect every other part of the body except the uterus, right? Gynecologists, their whole training is in the uterus party. Yeah, good idea. Thanks, Kathy. Yeah. So gynecologists, the bosses of women's health, aren't looking at any other part of the body except the uterus. So we're gonna pause here and make sure we're all on the same page and go through some definitions, because we're throwing around a lot of words here. Going chronological order backwards on purpose. Postmenopause, rest of your life after menopause. This can be a really long time. This is important. to understand the implications of living in a low hormone state for a long time. This can be 30 years, this can be 40 years, this can be 50 years, okay, because we're living so much longer. Menopause, one day. This is the 366th day after your last period, but that's only if you were getting periods. Lots of people don't for a whole bunch of reasons, medical reasons, surgical reasons, IUDs, ablations, PCOS. Average age of menopause in this country is 51. So menopause for most women happens in their 40s or 50s, but can happen sooner. Perimenopause is the time leading up to menopause. It is marked by hormonal chaos. That's what it is. Remember, if the average age of menopause is 51, perimenopause can last at least a decade. So this is most likely starting in the early 40s, but because some women go through menopause earlier, this can start quite a bit earlier and take people by surprise, and often does. It is marked by hormonal chaos, so there is not a lab test that can diagnose this, despite what the internet says. Hormonal chaos meaning your hormones are truly all over the map. Eventually, they're gonna trend down, but in the meantime, they're all over the place. So if you do a blood test, it's gonna tell you what you are on Tuesday, but that doesn't tell you what you are on Wednesday, so you really can't diagnose this with labs. What is a hormone? It's a signal created in one part of the body that's meant to act on another part of the body. I think of this as body email. A hormone receptor is the part of a cell that catches the hormone signal and it activates the cell. A neurotransmitter is a brain chemical that affects brain function. Hormones are neurotransmitters. Any medicine that contains hormone, we call hormone therapy. I'm going to say HT for hormone therapy, and we're going to talk more about that. There's two types. Bloodstream, the other word for that is systemic. It travels in your entire body and affects your entire body. Doesn't get into pelvic tissue very well, though. That's interesting. Pelvic HT, the other word for that is local, only affects the pelvis, not something that goes in the vagina. Now, there are hormone receptors for estrogen, progesterone, and testosterone everywhere in your body. And every organ can have symptoms when the hormones cycle in the uterus party, when they falter in perimenopause, and when they stop in menopause. The symptoms can be mild, moderate, severe, lethal. We'll come back to that. They can be temporary, intermittent, or permanent. And sometimes they are so vague, especially in perimenopause. Just don't feel like yourself. And I want you to remember that line, just don't feel like myself. Because when your body is working well, you don't notice it. You don't even think about it. Incredible machine, right, that we mostly take for granted. But when something's not right, it will call your attention for sure. There's one menopause specialist said, real way to diagnose when you're in perimenopause is just when you start going to the doctor, like stuff feels weird for almost any reason. So coming back to that idea of pattern recognition, and we're going to start, focusing with our hormone goggles. How do you connect the dots if symptoms are vague? Like, I just don't feel like myself. Gynecologists might have a hard time with pattern recognition if symptoms are vague and have nothing to do with your uterus, right? But who's especially not thinking about your ovarian hormones? The eye doctor. Eyes get dry, vision changes, contact lenses don't stick to your eyeballs anymore. The dentist, gingivitis, gum loss, gum recession. The neurologist, headaches increasing, memory changes. The podiatrist, your feet hurt. The orthopedist, frozen shoulder. We'll talk more about that. The rheumatologist, arthritis, fibromyalgia. The psychiatrist, new or worsening ADD-like symptoms, difficulty thinking, brain fog, mood changes, depression, anxiety, panic, OCD, and even increases in addictive behaviors. Physical and mental health conditions are misdiagnosed or misattributed in menopause and perimenopause all the time. And we're going to go through some case studies. Looks a little funny there. Start with a woman in her 40s. This is a woman who's married with 2 adolescent-age kids. New depression symptoms. Went to her healthcare provider, who connected the dots and made a diagnosis of depression and gave her an antidepressant. Symptoms getting worse. She's feeling worse. She wound up going back to her provider numerous times, changed the antidepressant, added antidepressants, cocktail of antidepressants. This was getting bad. And this spanned about a year and a half, close to 2 years at time. It got really bad. She attempted suicide. She was fortunately not successful. But at that point, there was so much terror around the severity of her depression. She was given electroconvulsive therapy, formerly known as electric shock therapy. Yes, no improvement. And it was at this point that her husband, who was a physician, was terrified enough to think, like, what are we missing here? What could we be missing here? And as a last resort, she was given hormones. Now, this woman was in her 40s. She wasn't asked about her periods at all. She was skipping periods. She was in perimenopause. And within about a month of taking the hormones, she was back to herself. Yeah. This is an interesting case of a young woman in her 20s diagnosed with cancer who was given chemotherapy. And it was a very strong dose of chemotherapy. Someone who's really young, you're going to treat them pretty aggressively. They have such a long lifespan ahead of them. She lost a lot of weight with the treatment. And part of that was the severity of her treatment, but part of it was she couldn't eat. She was having trouble eating because she was having a burning sensation in her mouth. She was told it was likely related to the chemotherapy, and when that stopped, it would likely stop. It did not. And after the chemotherapy finished, she was having trouble regaining weight and regaining her strength because of this feeling in her mouth. She couldn't eat. Now, 20-year-old woman, right? No one asked what was happening with her periods, but they had stopped because the chemotherapy put her into a medical menopause, also known as a chemical menopause. And burning mouth syndrome is actually a really common symptom of menopause, but because we don't talk about it, right? We don't talk about menopause really under even normal circumstances. This is such an unusual situation that it wasn't picked up. Some far-fetched, I don't know how, menopause specialist heard about this case and suggested she try hormone therapy. Burning mouth resolved. She was able to eat, gain weight, get her strength back, and by the way, her periods did eventually come back. This is a case of a physician, a surgeon in her 40s who was experiencing heart palpitations. Really healthy woman, like good nutrition, exercise habits, never happened before. But scary to her. She saw her cardiologist. She had the $1 million workup, which was negative, and she was told, you're fine. But there was also no explanation for her symptoms. The cardiologist didn't ask her about her periods. She was skipping periods, but she did happen to see her gynecologist because she was having hot flashes, right? So a hot flash, this is something we recognize. And by the way, I forgot to mention, she had cut back on surgical hours and stopped driving her children places because she was afraid she was going to hurt somebody, right? So this is impacting her life, her home life and her work life. Because she was having hot flashes, and that's a symptom that we recognize commonly, the gynecologist put her on hormone therapy. Palpitations resolved. Palpitations are a very common symptom of perimenopause and menopause. The sinoatrial node that usually controls the heartbeat has hormone receptors, estrogen receptors. So when the hormones start to sputter with perimenopause, so can the heartbeat. This is a story of a woman in her 80s with urinary tract infections over and over again. She was in the emergency room many times. She was given antibiotics many times. In fact, she got a secondary gut infection from the antibiotics, which wound up spreading to family members. C. difficile is very common with heavy doses of antibiotics. But despite multiple rounds of antibiotics, her urinary symptoms did not improve. In fact, they continued to worsen. Now, this got so bad for this woman that she was not able to care for herself. Her family was no longer able to care for her. She wound up in a nursing home as a result of her urinary symptoms and the severity of her urinary symptoms. Now, no one's going to ask an 80-year-old woman about her periods, right? That would be preposterous. But her recurrent urinary tract infections, in fact, were caused by menopause, the long-term loss of menopause of something called GSM. It stands for genitourinary syndrome of menopause. And this is a long-term progression of tissue derangement and tissue dysfunction in the pelvis caused by the loss of hormones with menopause. We're going to talk quite a bit more about it. It is extremely common. It is extremely devastating, extremely expensive, and extremely preventable. Okay, Wonder Woman, let's make the invisible visible. What are the symptoms of perimenopause and menopause? Dry eyes, dry mouth, burning mouth, we talked about, dry gums, dry skin, dry hair, dry vagina. Hair thinning where you want hair growing where you don't want hair. New body odor, fun. New acne, fun. Also just feeling itchy. Neurologic symptoms, long list, and that is because hormones are neurotransmitters and they modulate other neurotransmitters, including serotonin and dopamine. So long list of symptoms here: depression, anxiety, feeling low, feeling rage, feeling irritable, panic, insomnia, brain fog, inability to concentrate, fatigue, profound fatigue, nausea, and then some really weird things like electrical current feeling, skin crawling sensations in the extremities, headaches, migraines, and because there are hormone receptors in the inner ears, ringing in the ears, tinnitus, vertigo, and dizziness. Now, hot flashes and night sweats, we've all heard of this, and with that 1 to 2 hours of medical training about menopause, that's what gets talked about, hot flashes and night sweats. That's because those are the only two symptoms you can't blame on anything else. You can't misattribute those. Yeah. The thermostat does often get a little wonky because there are estrogen receptors in the hypothalamus, but interestingly, not all women experience anything like hot flashes or night sweats, and sometimes it's just weird heat sensations like people say, like, my ears get hot or my arms get hot. It doesn't look like necessarily a classic hot flash. Breathing problems. There are hormone receptors in the lungs, so sometimes people's asthma medications stop working during this time. Scary. And metabolic. This is really important. This has to do with heart health and the cardiovascular system, the circulatory system. As far as symptoms, we talked about palpitations, that is very common, but also the numbers, right? The numbers on the cholesterol panel, we don't like them anymore. No change to nutrition or exercise, but the numbers can go up for cholesterol, for blood pressure, and of course, our favorite on the scale, right? The weight gain, especially in the middle. And all of these lead to increased risk in heart disease, and it is only at menopause that women's risk of heart disease jumps up to match that of men's, because prior to menopause, we have what is actually called the estrogen advantage. That's what it's called, because it protects your blood vessels, and we lose that protection when we go through this change. Gastrointestinal changes, new acid reflux or changes, alterations in taste, changes in taste. Gut function can go wonky. An immune system, there are hormone receptors on immune cells. We see far more flares and instability in autoimmune disease when women are having any times of hormonal fluctuation, and we know that's perimenopause, that's hormonal chaos, right? And we see this with lupus, rheumatoid arthritis, psoriasis, multiple sclerosis, lichen sclerosis, among others, and the vast majority of people with autoimmune disease are women. Musculoskeletal syndrome of menopause. For some people, this is the only thing that they feel, and very, very frequently gets misdiagnosed or misattributed. It can be joint pain, muscle pain, small and large joints, feet, frozen shoulder. I don't have any physical therapists here tonight, do I? No. If there are physical therapists, I'll always say, anyone you know about the 51-year-old shoulder? And they all go, yeah, the 51-year-old shoulder. This is menopause. Loss of muscle mass, and this can lead to weakness, balance problems, mobility problems, and bone thinning can lead to osteoporosis and, God forbid, fractures. And the pelvis. Okay, so we mentioned briefly genitourinary syndrome of menopause. We're going to come back to this a few times. GSM. Again, it's a progressive condition caused by loss of hormone in the pelvis. So it causes a slow, gradual distortion of the tissue there. And it can result in an awful lot of conditions we can treat. We can help all of these, okay? But overactive bladder, top of the list. Urinary leaking, nighttime urination, like waking up all night to pee. Urinary urgency, stinging with urination, with or without a UTI, can feel the same even without a positive urine culture. But UTIs, recurrent UTIs, UTIs after sex, pain with sex, problems with sex, decreased sensation, loss of ability to have an orgasm, pain with orgasm, and low libido. Bloodstream and or pelvic HT can prevent or treat most of those symptoms, in part, in whole, somewhere in between. Big spectrum there. Let's break it down. GSM, genitourinary syndrome of menopause, almost entirely preventable or curable with pelvic HT. It is hormone, usually estrogen, in an ultra low dose. It goes in the vagina in various forms: a cream, a pill, an insert, a pessary, a suppository. Hello, I'm Lennon. Pelvic HT, hi. Pelvic HT does not go into the bloodstream. It does not go into the bloodstream. You can start it at any age. You can continue taking it forever. It is safe for 99% of women, probably 100%. That 1% is women who have active breast cancer who are taking one type of medicine called an aromatase inhibitor, which is an estrogen blocker. That one is still probably okay to use low-dose pelvic HT, but that conversation needs to include an oncologist. So that's important to know. This, by the way, is over the counter in many countries. This is so low dose. But you have to be, I try and warn my patients, when you get the prescription home and you open the package insert, it says something to the effect of your doctor is trying to kill you with this medicine, because the FDA says that for now anyway, you have to have the same warning on any form of estrogen. So estrogen in a high dose orally, they have put the same warning as this ultra low dose vaginally. It does not apply. It scares the bejesus out of patients and prescribers. And the American College of Obstetricians and Gynecologists has been lobbying the FDA for at least 10 years to say this is not accurate. But again, culture of invisibility, this is not considered important. So the package label stays on, scares many women, and many women suffer as a result.
So it's not over the counter in the United States?
In the US now.
Oh,
yeah.
Do you have samples?
Yes, actually. But yes, not with you, but yes. Bloodstream HT. So this is systemic. These are the systemic formulations. This can be estrogen, progesterone, testosterone, comes in a bunch of different forms. There are specific uses that the FDA authorizes: hot flashes, night sweats, premature menopause, osteoporosis prevention if you've had some bone loss or if you have a family history of osteoporosis, and genitourinary symptoms. So these are the uses that the FDA has given its blessing to, but all the other symptoms, that long list of symptoms, both pelvic and or systemic HT can help with to some degree. So sometimes they're very effective, sometimes they're less effective. It takes a little, sometimes, tinkering to know. So loss of hormones can cause what I call with my patients upstairs and downstairs symptoms. We talked a bit about the downstairs, the GSM. We're going to go upstairs. Yeah. Depression and anxiety, very, very important. So what does menopausal depression look like? I'm going to explain it to you from the vantage point of a 22-year-old. Okay. 22-year-old came home from college to visit her parents. Her mom is my very close friend. And her mom told me that when her daughter came home, she was I believe her words were a hot mess. She was beside herself. She was cranky. She was crabby. She was argumentative. She was crying. She could not kind of get a grip. And this went on for a few days until she got her period. And then, my friend, her mom said, she turned back into herself. Remember, I don't feel like myself. Turned back into herself. The week before the period in the menstrual cycle is when estrogen and progesterone tank. They bottom out. This is a sneak preview of life without estrogen and progesterone. This is menopause. It can feel like doom. It can feel like irritability, headache, insomnia, angry, aching, fatigue. We know this as PMS. In severe cases, we know this as PMDD, premenstrual dysphoric disorder. This is also what's happening chemically in postpartum depression. Of course, there's other factors playing into that, but it's a low estrogen state. And in perimenopause, we see this with that feeling of, when the hormones fluctuate and they drop, don't feel like myself. you do eventually adjust. The body does equilibrate. It's an incredible machine. The new normal can be fine, but also sometimes it's not fine. And a diminished, decreased quality of life can be confused, and often is confused, with normal aging. And I can tell you firsthand, this is what I hear from my patients all the time, every day. I don't sleep anymore. There's just no more sleep, but that's just part of getting older. I pee all night long. It's just what you do when you get older. Can't have sex. It hurts too much. It's just part of getting older. Relationship problems, loss of intimacy, sometimes infidelity, just part of getting older. Having trouble functioning at work, whether that's thinking straight, finding words. Sometimes I've had women who are bus drivers have to leave their jobs because they can't stop peeing. It's all kinds of impacts on work, and people leave jobs early because of untreated perimenopausal and menopausal symptoms. Not going places because they're suddenly really afraid to drive. Someone today, a patient today, who just told me this, I thought, oh, can you come tonight to my talk? Not hanging out with friends, doing stuff that's fun that they like to do because they're afraid if they laugh, they'll pee, right? Afraid to socialize. Not going on activities that they know they like hiking or travel or something like that, because they don't know where the bathroom is, right? I think just part of getting older. We're not exercising, they want to, they need to, because everything hurts. All of these can contribute to depression and anxiety, and they do. And hard to tell sometimes which came first, the limitations or the depression, but there's treatment, right? Now, if you seek treatment, right, use your hormone goggles. Healthcare providers connect the dots they are taught to look for. They can diagnose depression and anxiety, and they will reach first for the antidepressants, right? Usually SSRIs, these are the most commonly prescribed antidepressants and anti-anxiety medicine. This is your Prozac and Zoloft and Celexa and Lexapro, right? There's more. Women are prescribed SSRIs far more often than men are. The most common age, 1/4 of American women in the perimenopause and menopause age group are on an SSRI, and this is also the age group that has the highest rates of suicide in women. So are we making the right diagnosis? Are we giving the right treatment? And is the healthcare provider thinking about the hormonal component or asking about periods at all? SSRIs can help with depression and anxiety, and they can be lifesavers for people, and I don't want to minimize that in any way. But they may not help, or they may not help much if the problem is hormonal, right? And they can make perimenopausal or menopausal symptoms worse. What are the side effects of SSRIs? Flat mood, bone loss, weight gain, low libido, sexual dysfunction, and SSRIs carry a black box warning for suicide. Now, of course, we always have to weigh the benefit and the risk, not just with medicine, with anything in life, but how the treatment options that were offered, we have to think about how that's reflecting cultural ideas, right? What we talk about, what we value, what we teach in medical training. And because of the culture of invisibility around hormones, are we making the right diagnosis? Are we giving the right treatment? I would argue the benefit of SSRIs may be overstated, and the risks often not discussed at all, and the risks of hormone therapy, HT, are usually overstated, and the benefits often not discussed at all. Hormones are the most effective treatment for symptoms caused by loss of hormones because you're treating the underlying cause. So we have a long list here of ways that we treat potentially hormonal issues with non-hormonal medicines. Okay, we talked about depression and anxiety with antidepressants. How about migraines? Medicines like Imitrex can cause dizziness or brain fog, right? So we're going to go through this list of things that can not only be missing the underlying cause, but worsening the perimenopausal or menopausal symptoms. Joint and muscle pain, even over-the-counter, things like Advil and Motrin can cause or worsen heart disease. Sleeping medicine, things like Ambien can cause, associated with falls and bone fractures. Acid reflux, things like Prilosec and Nexium over the counter can cause bone loss and osteoporosis. Palpitations, beta blockers that we most like metoprolol or labetalol can cause fatigue and weight gain. An overactive bladder, right? So now everyone's got their hormone goggles. Should all be thinking GSM? Yes, I do mean GSM. Overactive bladder, the medicines that are most often prescribed are called the anticholinergics. That's your Vesicare, oxybutynin, and trospium. They are associated with cognitive decline and dementia. Putting this in perspective, so it's close to 80 million Americans who are incontinent. The vast majority of them are women. 7 million Americans have dementia. Far more of them are women. This affects women disproportionately more than men. We know women outnumber men in nursing homes by nearly 4 to 1. For what reasons do women go into nursing homes? Urinary incontinence, dementia, weakness and immobility, and osteoporotic bone fractures. All are preventable, at least in part, by either pelvic or systemic HT. And what you can't see on this slide is that we have the pelvic HT that is so safe for 99 or really 100% of women. What percentage of American women do you think even get offered this, as opposed to these non-hormonal options like oxybutynin and Vesicare? It's 7% of American women, right? So yes, I have samples. Yeah. Okay, why isn't HT offered more? Well, perimenopause and menopause are considered women's health issues, right? That's the gynecology department, but most of the gynecologists are busy at the uterus party, right? That's what they're trained in. Most healthcare providers don't have hormone goggles, and in fact, some have hormone blinders. If they are taught to see midlife and older women as, remember the story of the WWs, right? Or women are too time-consuming, too complicated, right? And of course, there are legit concerns about safety. Is hormone therapy safe? Is hormone therapy safe? Well, pelvic HT, we said, yeah, 99% of women, probably 100. Okay, bloodstream HT. This is where it gets a little tricky. There is a common perception that this is poison, that this is going to hurt you, right? In 2002, there was a press conference that released the results, preliminary results from a medical study about hormone therapy. Normally, medical results are peer-reviewed and analyzed and published. This was not. There was a press conference and there was a media circus that ensued. It said hormones cause heart attack, stroke, and breast cancer. And sometimes they can cause heart attack and stroke. We'll talk about that. But what was primarily communicated and panicked about was the breast cancer scare. That was what was repeated over and over again. So a little truth in there. If you start systemic, meaning bloodstream HT, more than 15 years after menopause, you do have an increased risk of heart attack or stroke. That's real. If you start HT within bloodstream HT now, within 10 years of menopause, you have a reduced risk of heart attack, stroke, dementia, bone fractures, diabetes, colon cancer, pelvic dysfunction, pain with sex, and all-cause mortality. That did not make it into the press conference. It was in all the later analyses of this, but the message was out and the entire world ran with it. Hormone prescriptions plummeted, antidepressant prescriptions started to skyrocket. The breast cancer data is very interesting. It was found later to be flawed, and I'm going to talk about that more in just a moment. The risk of hormones took on such a magnified and cultural and medical message, and I would say reinforced this sense of invisibility with older women, because hormone therapy makes older women, any woman, feel better, often, not always, feel better. But this idea, the message that came out was, we don't care if you feel better if you're, for instance, sleeping at night, or you're not in pain, your joints don't ache, or you can, God forbid, enjoy a sex life. What's important here is your breasts, possibly at the exclusion of any other body part. Now let's talk about breast cancer now, because it's incredibly important and it's incredibly common. In this country, it's about 1 in 8 women. It's a very high number, and treatment can be grueling. The good news is this is no longer a death sentence for most women, 90-95% of women. And do we actually know what is the leading cause of death in women with breast cancer and breast cancer survivors? Do you know?
I know in general with women it's heart disease.
You got it. Yeah. 100%. Yeah. So does bloodstream HT cause breast cancer? Okay, so let's break this down. Number one, no, it can't. These are hormones your body has been making and producing your whole life. They don't turn against you. If you ever had a pregnancy, you were making enormous amounts of these hormones. And breast cancer is primarily, not only, but primarily a risk in older women who are not producing these hormones. Okay. Does not taking HT protect you from breast cancer? It does not. Most people who are diagnosed with breast cancer never took HT. And interestingly, if you think about it, since that press conference 22 years ago, when hormone prescriptions really plummeted, you could sort of look at the longitudinal data and say, like, okay, if there's no more, hormone prescriptions going out there, surely, we would see a drop in the rates of breast cancer. But the opposite has happened. There's a rise in the incidence of breast cancer. Okay, so what causes breast cancer? And the answer is we don't know. We really don't know. Genetics, of course, plays a role. The two biggest risk factors for breast cancer are older age and having breasts, really, and I don't say that in jest. But there are other clues that we know that increase your risk. Alcohol does. Lack of exercise, obesity, nicotine, and of course we talked about genetics. There is an association between bloodstream and breast cancer though, so it doesn't cause breast cancer, but if there's a breast cancer that is growing, it is growing for a long time before it's big enough to either be felt or be detected on a mammogram. If that is happening and you are taking hormone therapy and there's a hormone receptor on the breast cancer, it can cause it to grow faster, and that is true, but that is not causation, it's kind of an acceleration. And interestingly, the data consistently shows that women who took HT, who were diagnosed with breast cancer, had a decreased rate of death from breast cancer. Whether that's because they were keeping up with mammograms, I don't know, but it's interesting and consistent. Not going to get into this. This is a very dense slide, but possibly preliminary data saying that HT started either in perimenopause or within 10 years of menopause can decrease your risk of dementia and other neurodegenerative disorders such as Parkinson's. This is the kind of list of green light, yellow light, red light indications for hormone therapy. Red lights are breast cancer, heart defects, severe heart disease, stroke, or a history of a blood clot that was caused by hormonal reasons, either related to pregnancy or hormonal birth control.
What was the last one of the
I think congenital
red zone?
ASCVD risk over 10%, which means if you have like cholesterol through the roof or triglycerides through the roof, ASCVD is considered a marker. It's a calculation you do that you put in your blood pressure and your cholesterol and your weight and your smoke, a bunch of things that gives you a number. And if that number, that percentage is high, you're considered to be high risk for heart disease. Okay, so are there other options besides HT? Yeah, of course there are. How about the gabillion supplements out there that everyone is cashing in on right now? I hate to say it, I really do hate to say it, but all the data shows that the gamillion supplements out there don't have evidence behind them. They really don't seem to work. They might short term. That might be because of the placebo effect, which is real. It's real. If you think something's going to help you, you'll feel better. It just doesn't last. It's not going to continue probably past like the 3-month mark or so. By the way, the opposite is true. I like to always include this in here. Has anyone heard of the nocebo effect? So that's, if you have heard of it, yeah, if you think something's going to give you side effects, it will. Right. So if I have, patients, right, who are really like worried about the medicine, I tell them I'm going to secretly like put M&Ms in your medicine bottle, and you're still going to come back with side effects, because you're so worried about it. There's a lot of safety concerns with supplements. They are not regulated. This is the problem. And so they're not routinely tested. And when they are once in a while, there's all kinds of contaminants that are found, some of them poisonous. Also, the potency varies. And very often what's found is what's listed on the package label is not what's in the bottle. They're also super expensive. And the only exception to this is vitamin D3. Yes, you need it. Please take it.
How much do you recommend?
At least 2,000 units a day. International units.
Yeah. As supplements, do you use vitamins?
Yeah. Really, you really don't need them unless you're really malnourished. And in this country, it's not impossible, but it's hard to be really malnourished. Yeah.
Do you recommend calcium with the vitamin D?
You know, if you're getting good sources of calcium in your diet, I really don't. Yeah, yeah. So what else? What else will work? What if you really can't take HT or you really don't want to? Are there other things you can do? And the answer is yeah. And I go through this with my patients all the time in terms of what's sexy and what's not sexy. Okay, sexy is, can you just give me a pill because I want to feel better now? And sometimes I can't. Like sometimes the answer is yes. What's not sexy is if there's no immediate gratification, and it takes a lot of time and a lot of effort and a lot of energy and a lot of patience, but much bigger payoffs down the line. That's stuff like food, like real food, real vegetables, fruit, whole grains, fiber. None of us is getting enough fiber, and that has a huge impact on not just our health over time, our weight too. It appears, we're just scratching the surface, but it appears the gut microbiome is probably running the whole show more than we understand. And what it wants is unprocessed, diverse, colorful, real food, and sees alcohol as a neurotoxin. Sorry, I hate to say it, but yeah. Really interesting research in psychobiotics that's coming out, which are foods, not supplements, but foods that naturally contain probiotics and prebiotics. And they are connected with positive mood and improvements in mood. So this is fermented stuff like your yogurt, kimchi, miso, prebiotics. Notice the dark chocolate is on there, just saying. And legumes, beans, lentils, garbanzos, peas. Exercise, incredibly important for everything. And when my patients ask all the time, like, you know, just give me a supplement, just give me, you know, want the vitamin to it. Really need this stuff. And in ideally different types of exercise. The sweaty stuff, that hits your cardiovascular system. It'll help with weight, it'll help with sleep, it'll help with mood. But you need also some weight-bearing stuff or resistance training that helps with your bones. And you need the stretching kind of stuff because that keeps your joints healthy. Should be fun, shouldn't be a chore. I love the idea of exercise snacks, meaning just little spurts if you can intersperse them in your day. Don't have to join a gym, don't have to carve out an hour. I put on here Taylor Swift because I'll often tell the patients like, pick a couple of songs that you love a day, right? And just like dance, you know, carve out that 3 minutes at home, dance around your house to that song. That counts. And if you can do it a couple times a day, all the better. Get your grandkids in on it if you can. Yeah. Stress, no joke. Really working on stress. Playing, getting outside. We're so lucky to live on the Cape. Socialize, meditate. Really hard. If you haven't done it before, really, really potent. Even in tiny, tiny bits, 1 minute a day, incrementally over time, huge payoff, right, for stress. And breathing exercises. Do we want to do a breathing exercise? Let's do it. Okay, we're going to do box breathing. Take seconds. You're into it, right, Robbie? Let's do it. So box breathing, because you inhale for a count of 4, hold it for a count of 4, exhale for a count of 4, and then hold it. So we're going to do this all together, right? Inhale for 1, 2, 3, 4. Hold it in. 2, 3, 4. Let it out. 2, 3, 4. Hold it out. 2, 3, 4. Isn't that lovely? I've done a couple of times now, it talks and it just changes the whole room. So that's something you could do in here, especially after all the IT methods today. It takes seconds. You can do that throughout the day. Really, really, really potent effects. So more box breathing and sleep. Get some sleep. Really get the TV. If sleep is really challenged, get the TV out of the bedroom if you can. Bed is for sleep and sex only. No screen, no watching, no news. God, no news. No snacks. And alcohol is always going to impair sleep. And a word about alcohol, it does increase risk of breast cancer and causes all kinds of urinary stuff. So if nighttime urination is part of what's affecting sleep, if you can lose the alcohol, it's kind of a win-win-win. Putting it all in perspective. So I am not here to tell every peri and postmenopausal woman take hormones. No. I'm here to tell every peri and postmenopausal woman that hormones play a role, more of a role maybe than you think, in your outlook, your relationships, your self-esteem, your work life, your sex life, and potentially your future health. Healthcare providers may not see or recognize hormonally caused problems because they're not taught to look for them. Those are not the dots they're taught to connect, right? Increasing the invisibility. Seeing through hormone goggles takes practice because we all have some degree of hormone blinders. It's embedded in the culture and language. And healthcare providers sometimes echo cultural messages that look down on women, and this is a message we could take on ourselves, right? Because we often conflate decreased quality of life with normal aging. So some red flags to be aware of. If healthcare providers tell women, don't need to see a gynecologist if you've had a hysterectomy, don't need to see a gynecologist if you don't need a pap smear, don't need to see a gynecologist if you're not having sex, and don't need to see a gynecologist because they can do your pap smear. I hear this all the time. And I want to say, we're more than a pap smear. That's just a little test for a cervix. We are so much more than that, right? So if that's all it's reduced down to, we are missing, we are invisibling so much of our lives and our experience. So if you have a pelvis, please bring it to a gynecologist. You're using it, whether you're having sex or not. And let's talk about sex for just a minute, okay? Let's talk about some of the guy stuff and some of the girl stuff. It's estimated about 50% of men will have some kind of sexual problem or concern. Great, they've got the urologist. They are very comfortable diagnosing these issues, treating these issues. They can examine these issues and document them in the medical software. We're going to come back to that. Lots of medicines, they're cheap, they're easy to get, and lots of other choices apart from medicines, right? Let's take it over to the ladies' side for a minute. About 50% of women also will have a sexual problem or concern. Remember, gynecologists not getting much training, if any, in sexual dysfunction. They may not feel comfortable helping you with this. And if you're going to talk about sexual dysfunction in women, you got to talk about the clitoris, but we don't ever talk about it. And in fact, the top 2 medical software systems in this country don't even include it. Why does that matter? If you have an earache or if your hip hurts and you go to the doctor, you bet they're going to examine you. But if you have some kind of sexual problem in a woman, the clitoris is responsible for basically all orgasms, okay? And in all the medical documentation systems, they list every visible body part. You kind of go through and check them off. Is it normal? Is it not normal? If not normal, why? It's not even there. How can you help a problem if you can't even name it or talk about it, even in a medical setting, right? Sometimes sexual dysfunction in women is just about understanding that the vast majority of women, 75% of women, will not and cannot have an orgasm from intercourse alone. That means you are normal. Sometimes just knowing that, oh, they don't have sexual dysfunction after all. But we see this also mirrored in sex ed, in schools with kids, if they get any at all. You talk about the penis, they talk about a vagina, don't talk about a clitoris ever, right? So that means messages, don't get pregnant, okay. Don't get an STD, an infection, okay. But don't expect to enjoy yourself if you're female, and if you're a guy and you plan to have sex with a girl, no idea how to make sure she does have fun. God bless you.
Excuse me.
Yeah. So there are medicines that can help with female sexual dysfunction. There's a bunch. Has anyone here ever heard of the little-known medicine Viagra? Just curious. Anyone heard of that? Perhaps, yeah. Has anyone heard of Addy? Yeah, no hands. Yeah. So yeah, there's a bunch of options that are medicines for women. Invisible, right? We just don't talk about it, but there's a bunch. And we know too that with pelvic dysfunction in women, this is not just a sexual issue, right? Because we know GSM can have so many symptoms. This is something that's progressive over time. And this is the time of life when Medicare only wants to cover a gynecology exam every 2 years. It makes me livid, yeah. And by the way, just the estimated cost in dollars, not in despair, but in dollars for recurrent UTIs in this country is over $2 billion a year. Not a small problem. Yeah. So, hormone goggles. Happy World Menopause Month. Get your hormone goggles. They make body functions, body problems, cultural barriers visible so we can talk about them and improve them, right? This isn't about lifespan. This is about health span, right? We don't have control over our genetics, but we do have control over our choices, and there are so many positive choices we can make. The question is always, how do you want to age? Let's not see ourselves as WWs or let any healthcare providers treat us like WWs unless it's this WW. But wait, nope, postmenopausal Wonder Woman, okay, yeah, but really, it's all of us who are the Wonder Women. Thank you guys for coming. We had all our challenges at the beginning. Robbie, thank you so much for helping us get through that. Yeah. Do we have any questions? Yeah.
You said that there are all kinds of things for women's sexual dysfunction, but I thought that Viagra, there wasn't very good evidence that it helps women.
It does and it doesn't. So there's lots of other options besides Viagra for women, but there is a role for Viagra in women, and that seems to be if women are having sexual dysfunction, either orgasm dysfunction or libido stuff, specifically because of an SSRI, because remember, that can put a damper on sexual function. Believe it or not, taking Viagra in those women can help. Yeah, so it does increase, it's a vasodilator, meaning it increases blood flow everywhere into the pelvis, and that happens in women who take Viagra too. It just doesn't correspond with desire the way it does in men, but there are other options. Yeah, good question. Like Addy is a pill. The other name for it is flubanserin. Believe it or not, it's in the family. It's like a distant cousin of an SSRI, but it doesn't act so much on serotonin as on dopamine. So you would take it every day. It does have mild antidepressant effect. That's what it was originally tested for. And they were like, didn't do much for depression, but people are really enjoying their sex life when they're at it. Yeah. So you take it every day. Really, side effects, if you have low blood pressure, that one can be problematic. So that's something to be aware of. If you have more than 1 unit of alcohol a day, it's not recommended to use, but otherwise doesn't work in everyone. But the people who it's like 70% effective for women, and it works for those women, it works really well. Side effects with that, ready? Better sleep and weight loss. Doesn't sound so bad.
Do you prescribe that to your patients?
I do. Yeah. You know where I work, Kathy. Yeah.
So why isn't everybody talking about that?
Invisibility, right? Invisibility. And this medicine, like they make it impossible. We got to jump through hoops. My staff, my office knows we got to do all the prior authorizations. It's ridiculous. Why? Because bigger picture, we don't value, an enjoyable sex life in women. Yeah.
And then Vyleesi, you had mentioned.
Yeah. So Vyleesi is another option for low libido in women. It's really nice in comparison to Addy. Addy you do need to take every day. It's a pill and you take it at night. Vyleesi is not. You can take it just here and there when you need it. It's an injection and that can turn some people off, but it's really like okay. If that's, for some people, they love having the flexibility to just use it once in a while. It can work pretty well. There are some side effects with it. The biggest is nausea, usually. So oftentimes if I prescribe that when I give someone anti-nausea medicine to have, it's probably to take just in case. Yeah. And some once in a while, like a real weird cough from that one. But
You're nauseous and horny.
yes.
So that's
That's
the only use for that medicine,
For-
Vyleesi?
Yes. Yeah. But there's other options too. It's sort of more of a conversation, but there's some other options too. Maybe I should have a talk just on that. Maybe I should. Yeah. Everyone's going. Yeah.
I think I already know the answer, but is there any research on marijuana and CBD
For
any of the symptoms or sexual or otherwise?
sexual, yeah, I mean, so kind of, yeah. So it's really interesting. There's no evidence for it, but there's lots of anecdotal reports about it.
Right?
There's no studies, right? So I think there'll be some forthcoming, but part of the problem with that is like, yeah, can people get benefit from it? Yeah, but again, like, there's no studies or evidence, meaning like we don't know in what form we should be using it, in what potency, and so it's sketchy and hard to recommend. But there is some interesting work being done on like topical CBD, to the pelvic tissue. That so maybe is the answer, but I don't know yet because there's not enough
until
studies.
it's federally legal, then they can't even do research.
If they can, I mean, you're saying until it's recognized not class 1 that it can't be. I don't know. I mean, there's research being done.
My son has Tourette's, and I know that they weren't able to do studies in the United States. They were doing it in Israel or something.
Yeah, I don't know about that. Yeah. Any other questions?
Do you have an opening tomorrow?
Tomorrow, I mean, I don't. Yeah, come see me. But tomorrow, I'm actually giving a version of this talk to a primary care group. So I'm excited to talk more about this and to get this into more primary care ears, because I think we do have some cultural blinders up, and so I'm excited to kind of work in this. Yeah. What do you got?
Handouts?
No. Sorry. No. Yeah. I don't at this point.
How about cards with your information?
I did bring my cards this time. I always forget a ton, and I brought them today. Was that? Oh, yeah. And Rabbi, do we know? Are there any more questions?
Jaymie?
Yeah.
Jaymie?
Yes. Yeah.
Can you hear me?
I can. Yeah. Who's this?
Hi, it's Kim. First of all, excellent presentation.
Thanks, Kim.
Question though,
Oh,
if you have,
all the way from Florida, right?
yeah,
Woohoo!
on the Space Coast.
I love it.
If you start someone on SSRIs for PMS or PMDD,
Yeah.
obviously prior to menopause, once they hit menopause, should you be able to stop them completely?
Great question. Sometimes yes, sometimes no. But you know what? You can actually give systemic HT right before, like the week before the period, the same way that you would use an SSRI at the end of the menstrual cycle. You can use HT instead, oftentimes with much better effect. And then, like if you wanted to, whatever, again, after menopause, continue it, stop it, you can do any of the above. But if you're using an SSRI for PMS prior to menopause, the question is, should you expect to be able to stop it at menopause?
Yeah.
I mean, maybe. It's certainly easy enough to find out and see how they do.
Yeah. Okay, thanks.
But again, thinking about if that swing in mood is really because of the drop in hormones, then it might be a more effective treatment to use hormones rather than the SSRI.
Right, makes sense. Thank you.
Yeah. Any other? That's cool that people, this thing talks. Any other online questions?
I do see one more asking about migraines. They said my horrible migraines went away after menopause. What's the possibility of them returning if I start HT treatment?
It's a possibility. Yeah, it's a possibility. So that's, we often, I joke with my husband all the time, doing this kind of medicine feels like Hogwarts to me. We're kind of playing with, potions and cocktails. So sometimes we got to play a little bit. It is, and I do tell people with estrogen, if you're having headaches, I want to know about it. So I don't see it often, but yes, it can happen. Any other questions? Yeah.
I used to get really bad headaches during my period. If I was to start hormones, would that bring headaches back?
Really unlikely, but not impossible, but really unlikely. Okay. Yeah. Any other questions?
I can't take hormone replacement therapy because I had breast cancer and it was estrogen receptor sensitive. So I want a whole lecture about that.
Sure. Yeah, it's a good idea. Yeah. And the pelvic stuff, if you're just talking about pelvic symptoms, there's no systemic absorption, and ACOG, American College of Obstetrics, they endorse that.
I do that.
Good. Yeah, good.
And it's a little, it helps.
Yeah.
But, as you showed us, there's a list. There
is. Yeah, and we can talk more if you want to, but sometimes you got to tinker with that a little bit too, but again, in super low doses. But yes, there's other options. For if we're talking about genital symptoms after, breast cancer treatment, absolutely, there's other options too. Yeah. Maybe I should do another one on that. Yeah. Okay. Do we have any other? All right. Thank you guys so much.
Thank you.
Yeah.
Thank you very much.
Thanks for everybody who came online. So I've got cards if anyone would like, or maybe I'll put them over here. And I really, really appreciate you guys coming. And Rabbi, thank you so much for Yeah, you're kind of our hero today.
Well, it looks like I need to
All right.
see you, Charlotte.
Yeah.
Yeah, I've been in this forever. Wait, I just have this feeling that I'm fine.
Oh,
There's
wow.
nothing to me, and I've never done any hormone therapy because my mom had visual kinds of breast cancer.
okay.
So, well, but that's why I never had it be an option.
Yeah, and family therapy, family history is not an option.
Oh, It's not wrong, class, it doesn't teach it. Sarah? Oh, okay, where?
Go see a gynecologist.
Yeah, that makes
Oh,
sense.
okay.
Yeah.
I don't know what that is.
I mean, not that I've had any
I'm
issues.
sure, probably been in a
Yeah, let's
class or something.
Yeah.